Welcome to today's iReview session. My name is Yejun, a second-year medical student at the University of Calgary. Our team will present to you today about branch retinal artery occlusion as a link between ophthalmology and cardiology. Branch retinal artery occlusion, or BRAO, is a blockade of a vascular flow in one or more branches of a retinal artery. This leads to focal retinal ischemia and usually results in severe visual losses. The BRAO involves the artery at the retina, so let's examine that layer. Retina is the innermost layer of the eye, the outermost being the sclera and the conjunctiva, and the middle layer being the uvea. Uvea is divided into anterior, iris, and the ciliary body, and the posterior, choroid layer. And if you face the retina, there are different parts according to the area that you look at. The more nasal part has the optic disc, and you can see that in the upper right picture there. And this optic disc is the collection of the ganglion axons exiting the retina to feed the brain of visual information. The optic disc is also known as the blind spot because any light that converges on that optic disc will not be translated into electric signals in the nervous system. On the other side, more temporally, you'll see the fovea and the macula. This is where the highest concentration of cones reside and therefore the highest visual acuity. When you look at an object via your central vision, this is where the light from that target will converge. And of course, the main topic of this presentation, you cannot ignore the vessels of the retina. If you look at the retina through a fundoscopy, you'll see all those veins also demonstrated in the picture there, and you'll be able to visualize both the veins and the arteries. Veins are usually wider. The retina itself is composed of multiple layers as well. There's the famous retinal nerve fiber layer, or the RNFL, the ganglion cells whose axons will converge into the optic nerve, the inner and outer plexiform layer, and the photoreceptors, of course, composed of the rods for low intensity light and cones for the higher ones, and the retinal pigment epithelium, Bruch's membrane, which acts as the border between retina and the choroid. Here is perhaps a more helpful illustration of the retinal anatomy and also the context in the eye by which the retina resides. If you look at picture A, there's the light first enters through the cornea and then the anterior chamber. Iris controls the size of the pupil and therefore the amount of light that comes through. The light will then pass through the lens, which can refract the light and also adjust the degree of refraction. And then the light will go through the vitreous body, and then converge hopefully on the retinal layer. And there's a cross section of the retinal layer as well. It's just the layers that I talked about in the previous slide, but in pictures. So circling back to the BRAO, the reason for the retinal artery occlusion we observed in the previous anatomy slide is because something's occluding it, and it usually comes from the systemic circulation. Elderly patients, especially in their 70s, are at special risk. The other risk factors include hypertension, because it can create turbulence, and also carotid occlusion, whether because the artery is naturally narrower or because the elasticity has been lost. Diabetes can create a blood with especially high viscosity, and therefore it can clog the internal carotid more easily. And also cardiac valvular disease can cause stenosis, and this causes abnormal turbulence as the blood exits the heart as well. I mentioned turbulence because the blood is full of coagulating factors, and unneeded excess movement of the blood can cause undue clotting process. But the BRAO can be caused by other processes as well. More famous causes are the Hollenhorst plaques. If the patient has an abnormally high amount of cholesterol in their blood and has also been hospitalized for something like arteriosclerosis, then it is likely that the cholesterol can form embolism within some of the blood vessels. This happens because blood is a continuously flowing mechanism, and when the cholesterol deposits on the vascular walls and they build up, eventually some of the blood flow is going to take little chunks of cholesterol along with them. These are called the Hollenhorst plaques. Because they're so small, it can infiltrate to more deeper capillary networks all around the peripheral vasculature. It can invade the brain, and in this case, enter the retinal artery and block and cause BRAO. Calcification is also possible because of the heart valvular disease, and platelet fibrin plugs from arteriosclerosis is also a possible etiology. Here are more rare etiology of BRAO. If we have Pursh's retinopathy, the emboli can be created from the coagulation of leukocytes, because there are higher levels than normal of the white blood cells in the bloodstream. Fractures of the long bones can break the marrow and release lots of fat into the bloodstream, therefore causing a fat emboli. Myxoma or heart cancer can release the tumor cells into the blood, and they themselves will form little chunks of emboli. If the IV drugs are used, or if there's a bacterial endocarditis, septic emboli can form from the clumping of bacteria within the blood. Giant cell arteritis as a cause of anterior arteritic ischemic optic neuropathy can be a cause of BRAO, as well as other inflammatory diseases like dermatomyositis, lupus, polyarteritis nodosa, and vasculitis. Other systemic causes include migraines, compressions due to mass in the anterior part of the head, as well as coagulopathies, abnormal tendency for the blood to coagulate and form clots. These can cause BRAO. When the patient comes in with these symptoms, we should be suspicious of BRAO, and these are sudden and profound altitudinal or sectoral visual field loss, and some of that's demonstrated in the picture here. The characteristic is that it is painless. It doesn't hurt. It's unilateral usually, because clots enter just one of the eyes, unless it's due to a systemic illness. And if they've in the past also had a history of temporary vision loss or stroke or TIA, we should be cautious and rule out BRAO. And when we observe the eye, we might be able to see a focal area of retinal whitening, usually on the temporal other side of the optic disc. And this is because of pallor caused by not enough blood flow to that area. The similar observation can also be made in commotio retinae, where the retina is bruised due to external forces. And sometimes we might be able to see Hollenhorst plaques within the artery that's causing the BRAO. when tested with the Humphrey chart, the patient will have a visual field defect. To further investigate the BRAO, it will be important to take a thorough history to find the underlying cause behind this disease. For vitals, it's very important to check the blood pressure. Also check the vision, pressure in pupils with special attention to pupillary reflexes to light. And also, it will be a valuable test to perform visual fields. We should also check for any history of arteriosclerosis, any family history of high cholesterol, history of fractures, and any scalp tenderness, temporal pain, and jaw claudication. There are a lot of investigations that can be done for BRAO to find the underlying cause behind the occlusion. In terms of labs, we can check the FBS and the A1C to rule out diabetes, CVC and differential, platelets and the PT-PTT, protein C and S, factor V Leiden mutation, antithrombin 3 to rule out coagulopathy, and the SPEP is for multiple myeloma. ANA, RF are markers for lupus and rheumatoid arthritis, respectively, and sickle cell disease. We can rule that out too. BDRL and the FTA-ABS is for syphilis, and this is especially indicated for patients below 50. FTA-ABS stands for Fluorescein Treponymal Antibody Absorption Test. Yejun and CRP are inflammatory markers, and we need to do this especially for patients whose age is greater than 50 to rule out AION from giant cell arteritis. Some other investigations include the Fluorescein and Geography. When administering fluorescein into the bloodstream, if there is delayed or absent retinal arterial filling in a one branch or a capillary non-perfusion, this is likely indicating BRAO. OCT can also look at the cross-section of the retinal layer, and if there is thickened and hyperreflective inner retinal layer, this can indicate intracellular, not intercellular, edema. B-scan or an orbital CT can be used to rule out any compressive lesions, because we covered that this can be causing BRAO as well. If the patient has history of high intracranial pressure, such as vomiting, headache, nausea, and papilledema, according to your fundoscopy exam, then we could use B-scan or an orbital CT to see if there are any masses. So with every patient presentation, we should have differential diagnosis. As mentioned before, the retinal whitening could be due to commercial retinae from trauma, and it could actually be a vein instead of an artery, making it a BRVO instead of a BRAO. Without the fluorescein angiogram, we could mistake the CRAO for a BRAO, and CRAO with any branch artery sparing would be an exact opposite to the suspected BRAO. This is more of an urgent matter where everything except for that branch is occluded. Lastly, instead of just the artery, both the artery and the vein could be occluded. So like this picture warning says, this photo contains sensitive content. So if you're not a fan of opening the eyelids with speculum, fast forward a few seconds. BRAO is the occlusion of an artery, and all the tissues need constant perfusion of the blood via the vasculature. So BRAO is a very acute ophthalmic emergency that needs to be treated within at least at the latest a 90-minute window. If it cannot be attended and treated immediately, BRAO can even progress and cause tissue infarction in a way that the vision loss is permanent. The goal of the treatment is to move the emboli away and restore blood flow in that particular area of the retina for vision preservation. The mainstay of the treatment is to lower the intraocular pressure because IOP and the blood pressure needs to be balanced for the tissues to be adequately perfused. Therefore, the net perfusion pressure of the retinal circulation can be increased by lowering the intraocular pressure. This can be done by first trying a digital ocular massage to try to dislodge the clot, and also by using systemic acetazolamide or Diamox. This can be done IV or per oral. Beta blocker, like the timolol, can lower the intraocular pressure as well, and it's usually given topically as 0.5%, one drop every 15 minutes, and repeating as necessary. Anterior chamber paracentesis can also be performed. This immediately lowers the IOP to 0 millimeters of mercury. This procedure can be easily performed at the slit lamp. We prep the eye with the topical anesthetic as well as the broad-spec antibiotic like Vigamox and povidone iodine. You place the lid speculum on the eye as demonstrated in the picture, and the eye is grasped with the forceps at the nasal side of the limbus to hold the eye still, and also countertraction. And then the microsurgical knife or 30 gauge half-inch needle on 1 milliliter syringe without the plunger can be inserted parallel to the iris through the peripheral cornea at the other side of the limbus, the temporal side. And then the aqueous can be released in a controlled fashion. After that is treatment with topical antibiotics, broad spectrum, like the Vigamox, 4 times a day for 3 days. Same thing here. The picture contains sensitive content, and if you find holding the eye open with speculum and injecting something disturbing, then fast forward a few seconds. It seems like I've gotten ahead of myself here. These are the specific procedures of the anterior chamber paracentesis, written out in steps for you. We can also consider hospitalization of the patient for carbogen. This is 95% oxygen and 5% CO2, which can increase oxygenation and vasodilation as well. And hopefully the vasodilation can dislodge the clot. If giant cell arteritis is suspected, we will give systemic steroids, methylprednisolone, 1 hour IV, 4 times a day for 3 days, with a very slow taper. After 3 days, no more than 2.5 milligrams of decrease per week. Prognosis of BRAO varies depending on the severity and the specific case. Retinal pallor fades and the circulation is restored over a few weeks typically. The prognosis is good if the fovea, or the central the part of the retina responsible for central vision, is spared. 80% maintain vision of 20 or 40 or higher, or better, I should say. Most do have a degree of permanent visual field loss. 10% risk of BRAO occurring in the fellow eye is present. The Hollenhorst plaque was one of the items on the list that can cause BRAO. This can also be seen in carotid artery disease. Carotid artery disease is an occlusion of the carotid artery, and this is caused by accumulation of the low-density lipoprotein in the internal carotid artery. The accumulation then can form plaques on the artery wall. Several risk factors that can raise the likelihood of plaque formation is hypertension, smoking, diabetes, and family history of the plaque and the arteriosclerosis. Age, older the patient is, the more likely they will develop carotid artery disease, as well as obesity. The arteriosclerotic process narrows and stiffens the internal carotid artery, and because of the loss of the natural elasticity of the vasculature, it is easier to clog and form plaques on its wall. The plaques decrease the blood flow because it stenoses the carotid artery, and therefore there is not as much blood flow that's going to the head and the eyes. To compensate for that, the blood flow is going to increase, and that's going to increase the chance of plaques rupturing. This triggers a clotting cascade, and some of the plaques can even break off and circulate into the eye, causing BRAO. So carotid artery disease and the BRAO can go together. So to know more about carotid artery disease, patients with CAD can experience the trouble seeing because of the BRAO, numbness or weakness in the face or limbs as some of the clot enter the brain. They can have headaches with increased intracranial pressure, difficulty speaking, and also dizziness. This doesn't mean that everyone with carotid artery disease will experience all these symptoms, but the characteristic is that these symptoms have sudden onset with this disease. So the important component of investigation and treatment of CAD would be thorough history and physical exam. You should ask the patient about headaches and his family history of stroke, atherosclerosis, and heart disease. Not to mention, because we learned throughout this presentation, it would never hurt to do a fundoscopy and also test the muscle strength to see if they have any limb weakness. You should regularly talk to the patient and look for signs of incoherent speech and comprehension, and also listen to the neck with your stethoscope for carotid bruit. If suspicious for carotid artery disease, we should perform CT angiography head and neck. For treatment, if the patient has had a stroke, it's a good idea to assess for carotid endarterectomy, which is a surgical procedure to remove the clot that's causing all the symptoms. And in the long term, there is a mainly pharmacological approach. Antiplatelet therapy that includes aspirin 300 milligrams per once a day for 2 weeks, and after which you switch to clopidogrel 75 milligrams once a day. We can also initiate statin therapy to hopefully decrease the amount of LDL in the blood, and also maintain hypertension and diabetes aggressively. So a strict control of the blood glucose level as well as the blood pressure. That was a lot of information. We covered BRAO and the carotid artery disease. Here's a summary chart of everything that we covered today. This is a reference of all the resources that we've used for this presentation. Thank you for watching.